the role of immigrant workers in the care economy and potential policies that can foster a more inclusive care sector. So we will start our conversation with Dr. Andrea Velasquez, then Dr. Roy Thompson, Dr. Julia Gelat, then Faith Wiggins, and finally Dr. Paolo Abarcar as well. So I will leave you to you, Andrea.
Well, thank you, everybody. I'm Andrea Velasquez. I'm an associate professor at the University of Colorado, Denver. And I want to start by thanking all the organizers for having me today as a presenter. I have already learned a great deal from so many great presentations, and I'm looking forward to more engaging discussions. So today I will talk to you about the unintended consequences of immigration enforcement policies, and how these can affect the U.S. labor outcomes and its ties to female labor force participation, household production, and caregiving. And what I'm going to show you today is drawn from two papers that are co-authored with a great team of colleagues. And our research motivation, the main motivation, is on the one hand, the size of the undocumented population in the U.S., which in 2015 was estimated to be around 11 million individuals. But also on the other hand, we are also motivated by the different policies that have been implemented to address undocumented immigration in the country. Many of these policies with the express intent of reducing the size of this population through deportations. And this has led to a massive increase in both detentions and deportations. And just to give you a sense of that increase, in only a span of a decade, detentions and deportations increased by about 3,000 and 200% respectively. Of course, this has had important consequences on the immigrant community, which has been established previously in the literature. But what we know a little bit less is how these policies that were designed to target the immigrant community have also had consequences on the labor markets of U.S. citizens. And what we want to do is to explore those relationships, and by doing that, we are going to highlight the importance of immigrants, not only potentially on the effect of the gender gap in the U.S., but overall their contributions in the U.S. economy. And particularly what we are going to do is to focus on the effect of secure communities. This was a federal policy which increased information sharing between local police and the federal government with the idea of facilitating the detection and removal of undocumented immigrants. And in fact, under secure communities, approximately 500,000 of undocumented immigrants were deported between 2008 and 2014. Most of them were male. And what is important too when we think about potential mechanisms that I'm going to talk about later in the presentation, although the policy intent was to target and remove violent criminals, in practice it increased the risk of deportation among all undocumented immigrants. And actually, advocacy groups have alleged that secure communities provided a way to use minor violations to target the Hispanic population. So what I want to show you here are some basic demographics of the deportees under secure communities, and I want to highlight two things here. The first one is that you see that Hispanic males are overrepresented in the data of deportees. And the other thing that you can see here is that only 18% of those who are deported were convicted with a violent criminal conviction. So what happens under secure communities or these other immigration enforcement policies is that now we have a sense of fear among the immigrant community. This is going to lead to these chilling effects, and I'm going to tell you throughout the presentation that this is an important mechanism that is going to have an effect on the labor supply among undocumented immigrants. So we have two main research questions, and we want to start by understanding what is the effect of secure communities on the labor supply of undocumented immigrants. And in particular, we want to know what is the effect for female undocumented immigrants in the sector of household services. Why they should be affected? Well, directly because of the increase in deportations, but also because of this idea of the chilling effects, which is going to impose a cost of working outside the home or or searching for a job. Once we establish that relationship, we want to know, is there any spillover effect for the labor supply of US citizens? And who should be affected? Well, our hypothesis is that those that should be affected are the ones that rely the most on using the services that are provided by immigrants. And who are the ones that are using the most these services? We are going to hypothesize are highly educated US citizen mothers. They are going to be the ones that spend a larger fraction of their income on outsourcing household work, but as has been discussed throughout the day, they also spend most of the time on household production and caregiving. So our hypothesis is that the main effect is going to operate through changes in prices of household services. And why we expect that, again, something that we have learned over the day, and Julia is going to talk to us more about this overrepresentation. Well, there is an overrepresentation of undocumented workers in household services work. So the causal chain that I'm going to propose is very intuitive. What is going to happen? Secure communities is going to affect the labor supply of undocumented workers. This is going to push prices up. And now we have a part of the population that cannot afford these household services anymore with these higher prices, okay? And now we have these women that need to reallocate their time from the workforce to household production and caregiving. Our findings support the hypothesis. What we find for undocumented immigrants is a decrease in their labor supply in household services. And something that is very important for this discussion in the immigration discussion is that immigrant workers are not substituted by US workers. So we see that overall there is a reduction in the labor supply in these occupations. So we see this shortage of workers in these occupations, and of course then prices of outsourcing household production is going to increase. When the prices increase, our hypothesis is that we have a part of the population among US citizens that cannot afford these prices anymore. That is exactly what we find. We find that highly educated US-born mothers significantly reduce their labor supply in response to these policies. And the effects are particularly large for mothers of young children, who are the ones that rely the most on childcare. Just to give you some numbers, the reduction is about of like 1.3% on working hours. And this is just like a nice graph, like this event study that shows you here the vertical red line represents the time when secure communities is implemented, and we see that is once our secure communities is implemented that we see significant reduction in the labor supply of mothers of young children. And maybe you might be wondering, yeah, but maybe there are many other things that are changing at the same time. But what we see that is very interesting is that US citizens who we think, and the data shows that rely less on outsourcing household services, are not as affected. Highly educated women without children or highly educated males, their labor supply is not affected by this. Interestingly, too, mothers living in their state of birth who might be more likely to have access to informal care, just like grandparents, are less affected. So now, just to conclude, with our research, we make an important policy, these results have important policy implications given the current debates about immigration policies. This is very relevant in an electoral year, not only in the US, but across the globe. And we need to think about moving forward, what are the policies that we think are going to be the most effective to really offer to the immigrants the fair economic opportunities for them as well. And these fair economic opportunities should not only be relevant in the labor market, because something that we see, because something that we see and that we highlight is that the reduction in the labor supply is not only because of deportations, but also because of the change in the political climate towards immigrants for those who stay in the US. So we need to think about how to change those conditions, not only in the labor market, but overall for immigrants. We also contribute to like a broad literature examining the effect of policies on female labor supply and time spent in household production, especially around the birth of a child. The decline in mothers' labor supply as a result of this immigration policy may have important consequences for the gender gap because there is an effect on their progression, in their career progression. And this can have important consequences in children's well-being. So although we see only short-term effects, we see this piece of evidence only as a first step to analyze the full impact of immigration enforcement policies on mothers and their families' well-being, and we just highlight the importance of understanding the whole effect for citizens and immigrants. Thank you, everyone.
Thank you so much, Andrea, for such an interesting research, and your policy implications, I think, they're really important for the discussion. Before open up to questions, I have two questions for you. So under the policy, under secure communities, you mentioned that more than 90% of those who were deported were male. Were you surprised to find an effect on the labor supply of undocumented immigrant women? And can you build more on those mechanisms?
Yeah, this was a very interesting thing for us to learn, and I advise you if you are interested in this. There's amazing work by Professor Carolina Valdivia. She's at UC Irvine, and what we learned, and she describes this so nicely, is that with interior immigration enforcement policies, the geography of the portability changed. And here I'm quoting her. And before, the fear maybe was only when the immigrants were crossing the border. But now the geography of the portability has changed to places like the grocery store, or just by driving if there is a DUI stop. And she has this powerful quote of like a woman that says, "I'm going to work today, but there is a DUI, the stop. The police is there, checkpoint, the police is there. I'm not going to put myself in risk today. I'm going to stay at home. I'm not working today." So this is exactly what we want to highlight, that is not only the deportations that is going to have an effect on the labor supply of undocumented immigrants. If they don't feel safe, if they feel afraid, that is also going to affect their decisions. And the labor supply is only one of so many dimensions that they could be affected. But what we needed to understand is that their well-being has spillover effects for citizens as well. So yes, we that was one of the parts that it was so important to understand, like all the intrinsic stories of immigrants.
Yeah, thank you so much. And my other question, which relates to some of the figures, or the figure that you showed, is that there is an extensive literature that provides evidence about this motherhood penalty, right? Like the time where the first child is born. And so you mentioned that you find significant effects, especially around the birth of the first child, right? Do these results contribute to this discussion, and in what sense do they contribute?
Yeah. So the figure that I showed you is the effect for mothers of young children. So these are mothers of children 0 to 5, and those are the ones that depend the most on childcare, right? But we also wanted to contribute to this literature, the child penalty, and can they rebound? So what we see is that what happens is if the exposure to secure communities happens when the kid is between 0 to 2. And can they bounce up, right? And we see that they don't, which is very similar to the child penalty. So if they are exposed to secure communities when the child is between 0 and 2, if we see what happens when they are 3 to 5, the effect on the labor supply of women persists. So it's not that, okay, I don't have access to this help when they are so little, but once I find someone else, I can go back to my previous labor supply. We don't see that is happening. So that's why it is important to think about what are the policies that are going to help highly educated women to reduce their gender gap, but at the same time, give the right, fair economic opportunities to immigrants.
Thank you so much, Andrea. So anyone has a question for Andrea before we move to the... Yeah.
Were you just looking at domestic work, or were you also looking at like direct care workers, like personal care aides and home health workers and things like that, which we also know are disproportionately undocumented immigrants? So
that is such a great question. So we use the American Community Survey, and the occupations that we use are going to be those that are under housekeeping and caregiving at home. So that would include childcare, but also care of elders. So yeah, those are the occupations that we look at. So, but nothing about like healthcare, for example, in nursing homes or things like that. Yeah.
Any other questions? Okay, well, thank you so much, Andrea.
Hi, everyone.
Okay.
Can you hear me? Okay. Hi, everyone. I'm Dr. Roy Thompson, and I'm a postdoctoral fellow at the Sinclair School of Nursing, University of Missouri. And I, get to segue into the impact of immigrant nurses in long-term care. As was mentioned, immigrants are disproportionately, overrepresented in long-term care settings. Many, as are called low-skilled workers. I do not like to use that term, but I will focus on the registered nurses or the more high-skilled workers. So to begin my presentation, I did an integrative review to really find out what are some of the factors driving international nurse migration to the U.S. and what's the impact on long-term care. And so from my research, most of the drivers are socioeconomic in nature. In most of the nurses who come to the U.S., they are from low and middle income countries where they make less money. There's less opportunity for professional advancement in their home countries. In terms of where they work, for example, in hospital settings, they have less staffing, they have less material resources to work with, and nurses really are trying to, move up. And there are also some contextual factors to that drive nurse migration from low and middle income countries to the U.S. For example, nurses typically migrate from English-speaking countries to the U.S. Nurses typically come from countries that have a colonial history with the U.S. or Canada or the U.K. And a lot of the countries where nurses migrate from to, they have similar nurse training and curricula that exist in the U.S. And we find that a confluence of these factors drive migration intention, and nurses then migrate to the U.S. And then looking at the composition of nurses who actually come to the U.S., right? In some cases, they represent up to a quarter of the workforce in nursing home settings, right? And they mostly migrate from the Philippines, the Eastern English-speaking Caribbean, and Sub-Saharan Africa, because some of these countries are considered to, overproduce nurses, which I totally disagree with, but most belong to racial and ethnic minoritized groups. Most identify as Asians or Black, and we typically have a higher proportion of men or males who are immigrant nurses who are employed in long-term care. There are times that medical doctors retrain as nurses to get into the U.S. workforce, and most of these nurses are multilingual. And when we're looking at some of the care issues, some of the interactions within some of these long-term care settings, we find that there's a lot of exploitation of immigrant nurses. Typically, they're given the undesirable shifts. They're given, the night duties that nobody wants to do. Sometimes their patient allocation is very inequitable and unfair. But you do want a better life, so you come to, so that you can get an increase in your pay. There's a lot of racism in the nursing workforce, actually. And, nursing is supposed to be a caring profession. I'm a registered nurse, but unfortunately, we do have some work to do. There are mixed findings in terms of wages, but particularly for low-skilled or direct care workers, their pay is usually less than their American colleagues. But these nurses are most likely to stay within the long-term care workforce. But because of language differences, there is communication barriers. But what we find is that the more immigrant registered nurses that migrate to the US, there's an improvement in health outcomes, right? But in some cases, there's a worsening depending on the nurse's country of origin. And so I did research looking at just comparing some of the employment outcomes between immigrant nurses and US nurses. And what I found was that immigrant nurses typically have higher human capital compared to their US counterparts. And this is because these nurses are typically more qualified. A lot of them come here already baccalaureate prepared, or they have the masters, or sometimes they have the PhDs. They have more years of nursing practice, but they come and take lower positions in the US long-term care sector. My work also found that there's no difference in terms of, no statistically significant difference in terms of salaries between immigrant nurses and US nurses. But to my surprise, immigrant nurses work less than US nurses, work less hours, and they make significantly higher wages compared to US nurses. But I did mediation analysis, and that's because they typically have higher human capital. So they're able to negotiate salaries, they're able to move from state to state for better employment. And some states employ more than others. But I also wanted to look at their experiences. So we have these big quantitative data that says, okay, they're doing better in terms of their productivity and how much money they make. But in terms of their experiences in the workplace, many of the nurses are impacted by the characteristics of the facilities in which they work. So a lot of the nurses typically get employment in facilities that are for profit, poor staffing. Many times they're not integrated in the workplace as they should or smoothly, because sometimes orientation is like 1 or 2 days, right? And then they're given like 60 patients on a nursing home ward to take care of. Right? There are also cultural differences between immigrant nurses and US nurses due to language and accent differences. And this actually worsened during COVID-19 when persons had to wear masks. So the mask kind of made it difficult to make out the accent of your colleague or nursing home residents who may have like dementia. And there's a lot of discrimination in terms of racism, especially among nurses from Nigeria and Jamaica. We find that nurses who migrate from Asia, they typically identify more with American culture, and so their experience transitioning into the US labor market is very different. So in terms of some of the policy implications, there has to be policies that strengthen migration or the implementation of migration tracking systems. It's very difficult to know the actual numbers. And the nature of migration is that people are moving, and so it's difficult to keep track of who is moving where, right? There has to be, I think, policies that strengthen also human capital, because there are differences between US nurses and immigrant nurses. And my research shows that the US nurses are typically more likely to leave the workforce. So what can we do to build, capacity so everybody is on equal footing, everybody is getting the same pay? Policies also that are culturally sensitive, that strengthen orientation programs, right? And the onus is not just on immigrant nurses coming here to be oriented. Like our American colleagues, they need to be oriented as well to the culture of these nurses and the long-term care residents as well, so that there is not this barrier in terms of how we interact with each other, right? And there has to be a concerted effort to address the racism that is in nursing. And what we do find is that, like the higher the nursing positions go, the less diverse it is, right? And that's a systemic issue that really needs to be addressed rather. And so these are my references. These are my contacts. My shameless plug, I'm on the job market, so happy to have conversations with anyone. Thank you so much.
Thank you so much, Roy, for such fascinating presentation. So before, again, I open up to questions, I would like to ask you, what would you say are current research priorities as it relates to this topic of immigrant nursing staff in the long-term care sector?
So based on some of the gaps that are in the research, I think there has to be more research that tracks, I think, immigrant nurse staffing trends over time and see how that relates to health outcomes in nursing homes or within long-term care setting. The argument I make is that immigrant nurses are beneficial to the U.S. Nursing labor economy, but I think more rigorous methods using longitudinal, designs. I think if you can show how do these nurses impact health outcomes over time, the migration policies may actually favor them coming to the U.S. Currently, like the policies that are in place is to keep immigrant nurses out of the U.S., which is crazy given that they have such high human capital and they're typically more qualified and have years of experience. So definitely that's one of the policy or research priorities I see.
Yeah, well, thank you. And
Thank you.
on the policy side that you mentioned, are there any current federal policies that will shape the recruitment and retention of these immigrant nurses?
I would say yes. Well, currently, the Centers of Medicare and Medicaid, they're proposing to have minimum mandatory staffing in nursing homes. And I think that's a challenge because nursing homes are notoriously short-staffed, right? And so if you make that mandatory, how is it that nursing homes are going to, fill those staffing needs? And this is like, decade-old problems. So recruiting immigrant nurses may be one strategy to address some of those, to meet those CMS mandates that are coming down around, mandatory staffing. Yeah.
Great, thank you.
Thank
Any
you.
questions for Roy? A question.
This is just anecdotal, but so I don't know if it's true in general. But I've noticed in the Washington area there are a lot of small facilities of long-term care that are basically run by immigrant nurse entrepreneurs. And have you noticed that in data?
So that does exist, and I think you see a lot of it too in states like California. So the states where you see a lot of concentration of immigrant nurses are like in New York, in Texas, in California, New Jersey. Like these are the states that typically attract the most immigrant nurses, and they typically to concentrate in like larger metropolitan cities, right? The fact that immigrants are here is also a magnet for other immigrants, and the larger facilities are typically in like the big urban metropolitan areas, and those facilities too can recruit nurses internationally. But that's definitely many immigrant nurses do operate small long-term care facilities, and there's research too that shows that those owners experience a lot of racism from like the state and federal regulators who come and do, evaluation. So yeah, thank you for that.
There is another question. Yeah.
Okay.
Thank you. My name is Ada. I'm Nigerian American. So I wanted to find out what your data shows about immigrants who were professionals back home and coming over here decide to go into nursing, right? Because as a lawyer back home, I knew I got the pressure as well. Hey, go do nursing. I'm like, no, right? So I want to find out what. It wasn't my passion, so I just let myself be pressured. But I want to find out, like, what's the data showing and how many of such moves and changes and what really influences it is really about the money, right? Because I'm not still sure why a lot of maybe immigrants from sub-Saharan Africa come over here who were professionals back home and just pivot into the nursing field.
Okay, so most of the data that I look at are registered nurses, and these are nurses who are trained nurses in their countries before they actually come to the U.S. So they already come as professionals. But in terms of what's driving that type of migration, from my work, it's mainly socioeconomic drivers. People do want better living conditions. But the U.S. is also very strategic. The U.S. has a lot of staffing companies or staffing solution companies that exist in low and middle income countries, and they're actively poaching nurses to come to the U.S. So it's not just, we all want to migrate to the U.S. They actually go into these countries and recruit nurses, and they offer them the green cards, and they typically not just offer the nurse, they offer the entire families green cards that entices the nurses to come. But when they come, oftentimes they're locked into these legally binding contracts like, oh, you have to work with us for 2 years and we take half of your salary, and if you break that, you have to pay us $50,000. Yeah, so there's a lot of exploitation that's kind of under, that's undercurrent. But thank you for that question.
Any other question? Oh, yeah, over there.
Thank you. Thanks so much for the presentation.
Thank you.
Can you hear me? Yes?
I can.
Great. Kind of on that question, do people end up getting green cards when they're promised them? And I guess also, do you have any data on how many people have a path to citizenship when they come through these types of jobs? And how many just sort of are here on a guest visa or something like that?
Mm-hmm. So there are visas that are that long-term care, and I don't remember if I think it's an e-visa, but there are professional visas that are granted to these nurses who come. But one of the challenges, sometimes there's a licensure issue. So there are many times a nurse may migrate to the U.S. and they have to work as like secretaries or do domestic labor, and that happens a lot in Canada until the RN licensure is sorted out in the U.S. because it does take a long time. So there's a lot of de-skilling that takes place when these nurses come to the U.S. I think once and oftentimes they're, and that's one of the the things that employers use to try to exploit nurses because they want their green cards and they want their visa. Sometimes there's threat of deportation if, let's say, you don't take care of these 60 patients or you don't take this shift that your American colleague doesn't want. And so sometimes they just suffer in silence. But typically after like 3 or 4 years, that's when they usually become more mobile and can leave after they've served their contract. Yeah. But thank you for that question. I don't know if I answered all of it, but I hope I did. Thank you.
I think there is one question here. No. No. Oh, okay. Okay. I think that, yeah.
Thank you.
No more questions? Okay, great. Thank you so much, Roy. So now we will have Julia Gillette from the Migration Policy Institute.
Great, thank you so much. Is this working? Yes, okay, great. Thank you so much to the organizers for including me in this really interesting conference. I've already learned so much, so I'm really happy to be here. I'm Julia Gillette. I'm the Associate Director of the U.S. Immigration Policy Program at the Migration Policy Institute. For those who aren't familiar, MPI is a nonprofit, nonpartisan think tank based here in D.C. We study a really wide range of immigration and immigrant integration policy topics, both here in the United States and around the world as well. And for students, I always like to point out our Migration Data Hub. It's a really helpful source of data online on immigrants in the United States, immigration trends, and immigration around the world as well. So I'm going to talk a little bit about the role that immigrants play in the care workforce, defined here as adult care workers, including home health care aides and personal care aides, and then child care workers. So immigrants overall in 2022, which is the latest year for which we have American Community Survey data from the Census Bureau, in 2022, immigrants were 17% of the U.S. workforce overall, but they were overrepresented in care jobs. So immigrant workers were 39% of home health care aides, 29% of personal care aides, and 23% of child care workers. Immigrant care workers are more likely to work in private homes than U.S.-born care workers. So over half of immigrant care workers are working in homes rather than in institutional, school, hospital settings, compared to 42% of U.S. care workers. Roy talked about the national origins of long-term care workers. For this definition of care workers, it's a little bit different. Mexico is the top country of origin, as it is for immigrants overall, followed by a diverse set of countries: Dominican Republic, Philippines, China, Jamaica. You can see the other numbers there. And you can also see that beyond the top 10 countries, there are a whole lot of immigrant care workers from countries all around the world. Immigrant care workers, like care workers overall, are predominantly women. 88% identify in the ACS data as female compared to 12% male. That binary is in the data, and that's why I'm only showing two genders here. In terms of citizenship, over half of immigrant care workers are actually naturalized citizens. I always like to point this out because I think when people think about immigrants overall, they overestimate the share of immigrants that are non-citizens and unauthorized immigrants in particular. But among care workers, over half are U.S. citizens. A little bit under half are not citizens, and that likely represents a mix of people on green cards, on temporary visas, and people who are in some kind of in-between status, and people who don't have any kind of legal status. The educational attainment of immigrant care workers is pretty diverse, and I think that this represents, as Roy was saying, some underemployment, people who have educational credentials that aren't well recognized in the United States or that they can't make use of because of their English language proficiency, but also people who are working at their educational attainment levels. So 27% of immigrant care workers don't lack a high school diploma, 30% have a high school diploma or equivalency but no higher education, 24% have some college attendance or an associate's degree, 14% have a bachelor's degree, and 4% have a graduate degree of some kind.
Let me know what happens.
Between 2010 and 2022, the number of care workers in the United States grew by over 800,000 positions. Immigrants accounted for more than half of that growth. So immigrants are really contributing strongly to the growth of the care workforce. And then looking forward, the Bureau of Labor Statistics projects forward which occupations it expects to grow into the future over the next 10 years and which it expects to shrink. They combine home health and personal care aides and expect that that occupational group will grow by another 800,000 positions. At the same time, they project that the number of childcare workers will actually shrink. And this all relates to the changing demographics of our country. So these are projections from the U.S. Census Bureau of the expected change in the number of children, of non-elderly adults, and then adults age 65 and older. What you can see is that the Census Bureau projects the number of children in the U.S. to shrink, and that's why there may be fewer childcare workers, but projects that our senior population is going to grow by 18 million over this period. So you can see how that will be driving strong growth for all kinds of healthcare occupations and healthcare support, and especially home health and personal care aides. This slide is breaking down the change in our population over the last 23 years. So this is showing the numeric change from the year 2000 to 2023 by immigrant generation. So first generation is people who were born outside of the United States. Second generation is children of immigrants, so people born in the United States to at least one foreign-born parent. And then third or higher generation is US-born people with US-born parents. If you look at the child population, you can see that our child population grew over the last 23 years only because of US-born children of immigrants. Same thing for young adults. In our prime working age population, that the growth there is being driven by immigrants and their US-born children. If it weren't for immigration, our prime working age population actually would have shrunk over this period, which shows that, you know, immigrants are an important part of the care workforce growth, but also our overall labor force growth and growth in many, many occupations. And then if you look on the right side, this is people age 55 and older. The number of immigrant pre-retirement and seniors is growing or has grown by 10 million over this 23-year period. And then the number of third and higher generation seniors and near elderly has also, I think that's a very rough definition, 55 plus, to call that near elderly, but I'm not sure what the right term is. People age 55 and older, it's growing, both among immigrants and among the third generation, which I think also points to the role that immigrant care workers can play, not only in meeting the numeric need for workers, but also the growing linguistic and cultural diversity of our older population in this country. Okay, this slide is a lot of information. This is showing the projected increase or change, I guess, in the skill requirements of two different occupational groups. All of this comes from, or the right side of this comes from Anthony Carnevale and colleagues at the Georgetown Center for Education and the Workforce. What it's showing is that in healthcare support occupations, so this is a broad occupational group that includes home health and personal care aides, but it also includes medical assistants, occupational and physical therapists, a wide variety of other healthcare support jobs. In these jobs, Carnevale and colleagues are projecting that the share of workers that will be required to have post-secondary education and training is going to grow quite a bit. Between the 2023 bar shows the educational attainment of healthcare support workers in 2023. So you can see that in 2023, 35% of healthcare support workers had an associate's or higher degree, and 57% had at least some post-secondary education or training. But he's projecting that in 2031, almost half, 48% of workers will be expected to have an associate's or higher degree, and 74% will be expected to have some kind of post-secondary education or training. The food and personal services occupational group, that includes childcare workers, but it also includes people who work in restaurants and a wide variety of other food-related occupations. It also includes people who cut hair and do manicures and fitness instructors. It's a very broad category, but you can see there the projections suggest that there will be less increase in the educational requirements. And then over on the left side of the graph shows the educational attainment of first, second, and third and higher generation immigrant workers in the United States as of 2023. So here, I think the important thing to focus on is the share of first generation immigrants or foreign-born workers who don't even have a high school diploma or equivalent. So given the educational requirements of the jobs of the future, especially in this healthcare support occupational group, that suggests that there will need to be quite a bit of upskilling of workers today. And immigrant workers face the same barriers that everybody else does in trying to increase their credentials in terms of the cost and competition with time for work and care responsibilities, but also face additional barriers in terms of English language proficiency, sometimes legal status, and sometimes literacy, depending on their educational background in their home country. So I think, it's really important to think about how important immigrants are to the future of our care workforce and what will be required, and think about immigrants in preparing the U.S. workforce for the jobs of the future. And with that, I will take any questions that folks have, and/or we'll move on.
Thank you so much, Julia, for such an interesting presentation. So again, I have a couple of questions for you. And so you showed us that immigrants are a big part of driving growth in the number of U.S. care workers. So my question is, how are these workers coming to the U.S., right? And or what visa pathways are they using in order to come here to the U.S.?
Yeah, so we're working in the U.S. with immigration laws that date to 1990, and the infrastructure was set even earlier. They're really not aligned with all of these demographic trends that I showed you in terms of, how immigrants are driving workforce growth. And our immigration system, basically our green card system, is for higher skilled workers, including registered nurses. And then our temporary work visas are for very particular pathways, either for high skilled workers like the H-1B visa that's used a lot by the tech industry, or for temporary and seasonal work like farm workers. We really don't have visa pathways for people who are filling jobs that have lower educational requirements or even kind of middle educational requirements. So even though immigrants are really driving the growth in the care workforce, I don't think that they're coming through employment-based pathways as care workers. In most cases, people are coming through family sponsorship through our green card system, or they're coming through humanitarian channels as refugees, or coming to the border and requesting asylum, or coming without authorization and finding their way into these kinds of jobs. So we really don't, our policies don't recognize how important immigration is in this workforce.
Thank you. And another question. Is there any way that immigration policies can be shaped to facilitate that needed migration that you mentioned?
Yeah, I mean, I think that we really need to rethink our employment-based immigration and recognize that immigrant workers are driving workforce growth and jobs all across the skills spectrum, and create pathways so that employers who have tried to find U.S. workers and can't find them, or in industries where there's just so much growth that every U.S.-born person and every immigrant person who wants a job could find one, that they could sponsor the workers that they need. Right now we have so many people coming to our border who just want to come and work, and we have so many employers who can't find the workers that they need, but there's no legal way to make that match between willing workers and willing employers. So it's like decades past time to update our laws. Unfortunately, I don't think that politics are there at the moment, but that's something that we can all work towards paving the way to happen in the future.
Great, thank you. Any questions? Okay.
The slide you showed with the I was just curious if the education levels that you showed account for education done in the home country of the care workers, or is that only U.S.-based credentials?
Yeah, this is people reporting their educational attainment, so it should be whether they earned it in their home country or in the United States. But as Roy mentioned, as we've talked about, sometimes people's credentials from the home country don't translate well into the United States.
I had a question about the graph at the end about the population growth of 55 plus, the pre-retirement age. Does the data show that that's a consequence of like family sponsorship? Like I'm thinking about people who have green cards or citizenship then applying for their family members to come and support them with caregiving, for example. So does it say sort of what the context of that growth is?
Yeah, that's a really good question. so the growth in the immigrant older population, how many of them have been here a long time and how many are new entrants, is something that I want to look at, and it would be quick to run, but I haven't done it yet. I suspect that it's a mix. We know that, a lot of immigrants came to the United States in the late 90s and early 2000s, and some of those folks would now be reaching this age bracket. At the same time, because our green card system is we have parent sponsorship, so people could be coming through that pathway, and then we have categories that are so backlogged, like our sibling sponsorship category. People wait 20 years before they're able to come, and by that time, they may also be age 55 plus. So I suspect it's a mix of new entrants and longer term entrants, maybe weighted towards longer term entrants, but yeah, it's a good question that I want to find the answer to.
Well, thank you so much, Julia. So now we will have Faith Wiggins from the Training and Employment Funds.
So, hi, my name's Faith Wiggins, and I'm really happy to be here. I'm going to do something I don't ordinarily do, actually two things. One is I'm going to ask for help advancing the slides because I'm, a little impaired here to do my notes. And that's the second thing. I usually don't use notes, but given that we have a certain amount of time and I have a lot of information I would like to share with the group, I'm going to try to use my notes so I stay on point and don't go over the period of time that I was assigned. So first, good afternoon. I'm so pleased to be here. I oversee at the Training and Employment Funds our workforce development activities, so program side of all of this wonderful policy framing that we've heard about. And my area of work covers our home care, nursing home, and community-based organizations where many of the low-income workers in healthcare reside. And just another qualification, I am not the labor union. We work adjacent to the union and to our employers. I'll get a little bit more into that in a minute. And before getting started, I also want to recognize the dozens of staff at TEF that make all of the programs I'll be sharing with you possible. So we have many goals at TEF. We try to be very comprehensive in our strategies, but at the core, we're developing career pathways. Okay. So our mission, let me start there. Our mission at TEF really is, embraces our opportunity working adjacent to the labor union to recognize that everyone deserves an opportunity to build a fulfilling and successful and family-sustaining career, earning wages that work. And given that our work that I'm speaking about is New York City based, where we know the cost of living is really tremendous. And we approach this by creating opportunities for historically marginalized healthcare workers. We've heard a lot about that this afternoon, and creating initiatives that really elevate the skill of the workforce to improve the quality of care that's provided. So our goals in doing that are pretty straightforward. We want to have comprehensive workforce development for the healthcare industry and really provide career pathways aimed to attract and retain the healthcare workforce, which after the COVID-19 pandemic is really difficult to do. People are leaving the healthcare workforce. So a bit more about who we are. You can go to the next slide. Our role at the Training and Employment Funds is the intersection of organized labor and our management or employer partners. So we collaborate along their mutual interests to create programs that ensure quality, skilled workforce, and a positive work environment, which we know really does inform keeping people in the healthcare jobs. So next, we've been busy since we started in 1969. I'm going to assume that these slides will go out to all of you, so not getting into all the numbers here, but during our tenure, we've provided opportunities for over 1.6 million workers. You can go to the next slide. And we do that through our strong partnerships, which are bound in many places through collective bargaining agreements, right, with our labor and healthcare partners. And I want to acknowledge the educational institutions that we work with. Otherwise, the programs that we have available would not exist. Next. So this has been mentioned in several rooms this morning here, that even though these are good quality healthcare jobs, over 70% of the workers represented by the 1199 labor union are in entry-level or low-wage earning positions. You'll see the majority are in home health and personal care, and the minority are in the registered nurses that we've heard about this afternoon. Next, please. And in terms of the diversity of the workforce, you'll see that it's overwhelmingly in New York City are these statistics. There, Black and African Americans are a high percentage, along with other non-white representation in the union workforce. Next. So we've also heard earlier about, just access to education and the challenge of that, a lot of that driven by the cost, right? So not to do a deep dive there because I want to get into our programs next, which really I'm going to focus on programs that were born out of the challenges of the 1199 workforce, largely immigrants, in terms of their barriers to educational opportunities, born out of language, citizenship status, and transferring their credentials to work in the U.S. Next, please. So at the Training and Employment Funds, we have many, many, many different educational and employment services. You'll be able to dig into this more if you want to look into the slides, but I'm going to start with, again, some that really focus on opportunities for the immigrant workforce. Next. And before jumping into that, several years ago, with the leadership of one of our staff, Maria Luisa Castaneda, who is an immigrant from Peru, we convened and looked at what really are our union-based educational philosophy and program standards, so that all of our programs are vetted through a lens of who we are as a labor management organization. So now to our programs. You can go to the next slide. First, we talked about this. We have workers who are coming to us from other countries. We help to navigate in that space of getting credentials translated and recognized in the U.S. That's a service that we provide, usually we take on the cost of that for union members in terms of getting access to operate in there at the top of their credential, right, by helping with those services. You can do the next slide. And at the core of our services are our citizenship program. It was one of the first programs started in the Training and Employment Funds. There we provide legal assistance, preparation for the test. That preparation is offered in both regular classes and classes for speakers of other languages. And for the last 10 years, we've also provided a significant reimbursement for the citizenship application fee, which now I believe is close to $800, which, that's a real barrier. So we're paying, I believe, $600 of the $850 for the application fee to our members. Next. And being that we operate in New York City, I had to throw in this picture of a trip that we took to Ellis Island a couple of years ago because, we really want to celebrate the 13,000 union members that have secured their citizenship through our programs. Next. So we start with high school. High school equivalency is required for most of the healthcare jobs, with the exception of personal care and home health. And even in those jobs, high school is a requirement, and we provide GED programs in both English and in Spanish, which is the predominant language. Next, please. And we have Spanish classes, and so many of the consumers of healthcare speak Spanish as the first language. We want caregivers to also speak Spanish if it's not their first language. Next, please. And we went one further. We developed a curriculum called the Language of Care, so that in nursing homes and other facilities, we've trained administrators, doctors, nurses, others at the bedside to speak the first language of their patients. So we've developed this program in Mandarin, Cantonese, Korean, Russian, so that better care could be provided in terms of activities and other bedside tasks. Next. And our largest program in this space is English for Speakers of Other Languages. We have two customized curricula that we developed. We call it our Pink Book, is for the home health aide population. Our Blue Book is general health care, but these curricula are customized for language that people will need on the job whose first language is not English. Next. And of course, in these days, we have to have tech. So we have experimented with many cell phone-based English language training programs, and also used cell phone-based and technology-based tools for assessing what level is someone starting at when they're getting access to programs. I'm almost done. Next, please. So I'm not going to go through this, but it does give a visual on how someone navigates through our programs to get to where they need to go, because we really want to have something for everyone that comes to our door. But what I'd love to end with is, next slide, is Emmanuel's story. So, because stories are the best way, right, to tell someone's experience. So Emmanuel says, I would urge anyone looking to pursue their education to utilize their 1199 SEIU benefits. The staff of the training fund are caring and supportive. Yes, they are. And the experience is once in a lifetime opportunity and has been truly life-changing. Members are able to achieve their American dream. Emmanuel started as a home health aide, and now he's about to graduate from medical school as a podiatrist. So the opportunities are there, the benefits are robust, not just in terms of education, but high quality health coverage, pension, and other benefits that we hope will attract folks to jobs. And Roy, let's make sure we change information, but also retain the talent that exists in the workforce. So thank you.
Any questions for Faith?
So my mother is actually an immigrant home care health aide, and I know that she works through an agency, but I don't think they're associated with any kind of union. So how do they connect with you? Like, how does that work?
So the labor union does a lot of work to drive non-union workers to union shops. There is some of the constructs are very wacky. So because there's a robust benefit package that costs money, and the funding for most home care jobs is through Medicaid, if that employer that's not union and not paying benefits, they can put more into wages than a union shop that's carving out resources for benefits. But I think the best way for your mom and other folks to access meaningful employment is to ask the questions. What's your benefit package? Do you have a labor union or some other sort of, worker place where workers can congregate and share as a means to decide whether or not that's a good place to work. And agencies don't provide those kinds of services and supports. Thank you.
Any other questions? So let me just ask one question and then we will move to the last speaker. So you mentioned a lot of these training programs, right? And so one question will be, what is the connection between workforce diversity and the quality that they can provide to their patients, right?
Right. I actually think Roy covered some of this. So, healthcare and caregiving is so intimate, right? And if and the relationship between the caregiver and the person they're caring for is very important. So having competency in terms of language seen as a competency really does improve the outcomes of a patient, because that dialogue between the patient and the caregiver is much more meaningful and honest, because that relationship can be built on a framework that improves care.
Yeah, I completely agree. As a foreigner, I think that that cultural barrier in the healthcare sector is important to address. So thank you so much, Faith. I think that we are just almost on time, on the interest of time, but at the end we can take your questions, sorry. Paolo, please, from Mathematica.
Yes, thank you. First of all, my name is Paulo Barcar. I'm a senior researcher economist from Mathematica, and I'm really pleased to be here to share some of my research and some of our work. So to cap off this session, I'm going to bring in a more global perspective and end with some proposal and idea for how might the US and other nations conduct migration policy to address healthcare workforce shortages. So just as a background, globally, we know that the world needs more healthcare workers. And some of the speakers earlier have already alluded to this, but the US faces a healthcare worker shortage, is projected to face a healthcare worker shortage because of primarily the aging population and increased demand for healthcare. But we must also recognize that healthcare shortages are universal and also exists in developing countries where the disease burden is even more significant. A common response in developed countries is to recruit foreign-born medical professionals, such as nurses from other countries, to plug the skill gap. And so I wanted to bring in two big questions in this case. One is, does this recruitment lead to even more shortages in poorer or less affluent nations? So does this lead to brain drain? And, in a sense, in other words, is the US merely passing along its problems to other nations? And in the next few slides, I'll talk about some of my research in this area. And then the second question is, if we can, how do we manage this recruitment so that it leads to some beneficial outcomes to both destination and origin countries, because healthcare workforce shortages are everywhere. So brain drain or brain gain, there's a long literature on this topic debating whether the migration of skilled professionals lead to a brain drain or a brain gain. On the one hand, there are those that argue that recruitment of skilled workers likely depletes poor countries of these workers, or brain drain. And this phenomenon is, even more concerning in the case of healthcare workers because of its potential to undermine healthcare systems in home country. On the other hand, there's also this argument that migration opportunities can encourage individuals to invest in skills and education. And because not everyone is able to migrate, not everyone will be able to migrate, there are more individuals who are skilled who remains at home, and this results in a brain gain. Despite the heated debate on this topic, little causal evidence exists. And so here comes our research. And so my colleague and I recently published this paper examining the brain gain debate in the light of the migration of Filipino nurses to the US. The Philippines is one of the top migrant sending nations in the world and the world's largest provider of foreign nurses. And the US is one of the most common destinations where they earn 13 times what they earn at home. And so we study this. We study this in the light of two policy shocks that happened. So in 2000, in the year 2000, the U.S. dramatically expanded the availability of visas for foreign nurses through the American Competitiveness in the 21st Century Act, or AC-21. And then in 2007, visas suddenly reduced to pre-2000 levels because the additional visas ran out. So we study these two policy shocks and the impacts of these policies. And this altered the migration prospects for many nurses, especially from the Philippines. And then we examine the effect of these policies on both the demand for and supply of education, basically the enrollment, graduations of nurses in the home country, the Philippines. And we use some unique administrative data on all migrant departures and post-secondary institutions in the country. Usually I talk about, as an economist, I'll talk about the empirical specification and all that stuff, but I'll skip all of that for now because of, in the interest of time. But this is what happened in one graph. This plots the yearly departures of the migrant departures from the Philippines yearly. And as you can see, in the 2000, when the US made available more visas for nurses, migration shot up to the country. And then in 2007, when the US contracted the number of visas available, migration went down. So I'll skip to the key findings. So the expansion and contraction of US nursing visas substantially increased and then decreased the migration of Filipino nurses. But what we find was that there was a huge and dramatic response in nursing school enrollment and graduation from this policy. So we estimate that nursing enrollment in the Philippines increased by 129%. Nursing graduates increased by 247%. And we estimate in the end that for each one nurse migrant that departed the country, there were 9 newly licensed nurses produced and remained in the home country. And so this is some evidence that there was a massive brain gain that happened. And we also find in other results that the supply of nursing programs expanded to accommodate this increased demand in education. So the supply response was concentrated among private schools rather than existing private schools, rather than the opening of entirely new nursing institutions. So these are just our results in graphs. This plots the 4-year nursing enrollments in the Philippines, and as you can see in 2000s, it shoots up from around 100,000 to over 600,000 students in nursing programs. And then we find similar results in terms of graduations, except that it occurs with a 4-year lag because studying nursing in the Philippines takes 4 years. So those are the results. I just wanted to end on a note on policy. And I think one of the key takeaways from our research and some recent research is that migration is a very powerful incentive for people to invest in their skills and educate themselves. And so the question is, how do we harness this powerful incentive to be able to address workforce shortages in general or shortages in healthcare? And so one potential idea, I think this one is proposed by the Center for Global Development, is to invest in these global skill partnerships between destination and origin countries. And these are essentially bilateral labor agreements where the origin country agrees to train more skills or more people in skills that are in demand and are in immediate need, but where the destination provides the technology and training and financial support to facilitate this training and provide comprehensive support to develop the institutions that are in the home company to do this kind of training. And in a way, this model gives people an option, a home and away track, and the trainees are given an option to stay in the home country or to move abroad. And the agreement, the model in theory would facilitate labor migration for those who would want to. And so maybe I'll end there because we're running out of time, and then open it up for conversation. So thank you.
Thank you so much, Paolo. So yeah, now I open up to questions, either for Faith or Paolo. I think that there was a question first here, and then we will move there.
Oh, thank you. My question is that because I'm from New York City and my mom is a home health aide, she's been a home health aide for like about 10 years. So I was just going to ask if there are any trainings and employment exposure to like recently new immigrants, but then also for older immigrants, because my mom's like about 55. So you have some immigrants, once they come into the country, especially to New York City, they tend to seek employment in home health agencies.
Definitely yes. So the average age of the 1199 home care workforce in New York City is about 52. So it sounds like your mother is right in line, and I'd be happy to share my contact information. We work with about 50 unionized employers who all are hiring on the home care side, and also there's opportunities if your mom were to become a member of the 1199 union for her to get access to other training opportunities so that she could perhaps advance to a higher paying role than home health. But home health is beautiful. I work with that segment of the workforce for over 20 years, and there's some excellent opportunities. I'd be happy to share my contact info.
Like, I just wanted to know, like, what types of careers are out there that can help people advance.
Yes, so in terms of our training and employment funds, many folks start in home health, as you said, because that's the access point, but they go on to licensed practical nurse, they might become x-ray techs, they might leave the field because they've built up skills and an employment history to move into something more administrative. So there's lots of opportunity, I think, once you're able to have a grounding and demonstrate your employability. And we have a whole entire department that's focused on employment services for the unionized workforce. So yeah, there's definitely opportunities and a career ladder opportunity for people to move up.
Thanks everyone for those great presentations. And this question's for you, Paolo. It's pretty small, but I'm really interested in the fact that the graduation rate went up by a much greater proportion than the enrollment rate. And is that to say that the fact that this visa was expanded meant more people completed degrees where otherwise they would not have completed those degrees?
Right. Sorry, yeah. The enrollment rate was like the enrollment for each of the 4 years. So it's like first, second, third, and fourth. And so there were more people. And then the graduation is just for the final year. Just to clarify, but the paper has more results, and we also investigate whether the increase in enrollments was because people were shifting fields or because more people were being induced to enroll who would otherwise not have gone to college. And we find that there was some shifting involved, but overall there was more people who were going to college because of the policy. We also look at failure rates, people who didn't pass. We found that after the policy, because of the migration opportunities, there were more people who failed the nursing licensure exams, but that there were so many more people who were taking the exams that in the end there were more licensed nurses. So I'd encourage reading the paper if you're interested in these results, but there's more there than I presented in 10 minutes. So.
Thank you so much, everyone. It was a great panel.